severe, very severe, whatever. Everybody has a short-acting rescue inhaler. Everybody's got their albuterol inhaler for acute symptoms. So everyone with asthma.
No, you're not doing that.
Long-acting beta agonist.
No, you're not. Stop right now.
Just
a piece of shit.
In your system. So whereas albuterol maybe only lasts for a few hours.
No, it said no.
This will last for and generally,
Conti.
beta agonists are given in consort with the inhaled corticosteroids. Usually, formoterol and salmeterol in inhaler form are also accompanied with that.
What you want, Condi? What the heck?
So,
okay.
The long-acting versus the short-acting. You should know that albuterol is a short-acting beta agonist.
Okay.
Short-acting beta agonists.
Here you go.
We give for acute.
Good.
And long-acting beta agonists are more so used on a daily basis for people with more mild, moderate, or severe asthma for control their symptoms. Okay, how about inhaled corticosteroids? So like any steroid, this works inside the cell, and so it gets into the cell and works directly on the DNA, and it's going to decrease the transcription and ultimately the production of inflammatory mediators, and thus that's going to decrease inflammation. So because a steroid takes time, it's not used for any emergencies whatsoever. You may give it during an emergency, but it's not used to treat the symptoms during the emergency per se. It's given to treat the symptoms down the road to make the patient better. But if you have a patient who's got a severe asthma attack, you're not giving them a steroid to load their asthma attack. You're giving them a short-acting beta agonist. So this takes time to work, so it's not used for emergency treatment, but it is used for asthma to ultimately reduce the symptoms over a longer period of time. So some of the things some of the inhaled corticosteroids you see are fluticasone, budesonide, triamcinolone, flumetazone, and there's more. There's a lot more. A lot of times you're going to see these inhaled corticosteroids in the same inhaler as you see the long-acting beta agonists. They're both going to be together in one inhaler. And that's because a lot of people who require an inhaled corticosteroid also require a long-acting beta agonist. And you'll see that when we get to the therapies. So you're going to, with the inhaled corticosteroids, this is going to be important when we talk about how we dose people. You're going to increase the dose with severity. So there's a low dose inhaled corticosteroid, medium dose inhaled corticosteroid, and high dose inhaled corticosteroid. Of course, for the USMLE, you don't need to know the numbers of the dose, but it's important to know that there are varying doses of corticosteroids, and that's going to be dependent, what dose we use is going to be dependent on the severity of the patient's asthma. Some of the other meds that are used are cromolyn. Cromolyn and indocromel is mast cell stabilizers. These may be better drugs in children. They're not so much, they don't work as good in adults. So this is something to think of in children as an adjunctive drug.
Don't scare her like that anytime.
Leukotriene receptor agonists, Filcast, and
okay, you want the book? Okay. Okay, here you go.
Particularly in,
you want this? You want this?
Okay. Long-acting beta agonist is not going to be
good.
So for instance,
one more.
Congestive heart failure. We might not want to use a long-acting beta agonist.
Good. High five.
Probably a little bit more important than their long-term asthmatic symptoms. So if we can get away with using something other than a long-term beta agonist, we try to. So these can be drugs that work for that can replace a long-acting beta agonist with, particularly in patients who are on beta blockers. So Filcast and Zafirloclast are those drugs that we use. Theophylline is another drug that's used as an adjunctive drug. It's very good for nighttime symptoms. So patients that are having a lot of nighttime awakenings, theophylline can be a really useful drug. And zelutone is a more recent drug. I wouldn't really worry so much about that with USMLE here for completeness sake. Okay, so this is the step-up approach for asthma. So now we've talked about all these drugs, it's good to know when we use them and how we use them. So if a patient, okay, let me go back. So there are 6 steps here. And usually patients are in 2, 3, or 4. Most asthmatics are in 2, 3, or 4. However, there are some that are in 1, and there's some that are in 5 and 6. So as far as 1 goes, the patients who are in step 1, usually these are the patients who they know their trigger. So they have exercise-induced asthma, or they have asthma, they can get asthma attacks around cats. These patients, all they need is their short-acting beta agonist, their rescue inhaler. They start getting asthmatic symptoms, they take their rescue inhaler and get out of the scenario that they're in, and that's usually enough for them. So if the short-acting beta agonist is enough for them and they're not experiencing persistent symptoms, then that is fine. You don't need to go any further. If they're using their beta agonist, the short-acting beta agonist inhaler, their rescue inhaler, more than 2 times a week, then you should move up and give them, in addition to their rescue inhaler, you should give them a low-dose inhaled corticosteroid. Like I said, that's with the use of short-acting beta agonists more than twice a week. That's generally going to be indicative of when you move up. So a lot of people are going to need a low-dose inhaled corticosteroid in addition to their short-acting beta-agonist. And the low-dose inhaled corticosteroid is going to give them sort of a basal level of relief throughout the day, and if they have a sudden increase in their asthmatic symptoms, then they can go back to their inhaler. But of course, if they're using it more than twice a week, they should definitely be not in step 1, they should be in step 2. If they're on the low-dose inhaled corticosteroid and the short-acting beta-agonist, and they still need to use their rescue inhaler more than twice a week, then we want to give them either a more longer-acting beta-agonist, or we can up their dose of their inhaled corticosteroid. Either of those would be okay. So we can give them a long-acting beta-agonist, like formoterol or salmeterol, and we can combine that with a low-dose inhaled corticosteroid, or we can combine that with a medium-dose inhaled corticosteroid. Doesn't really matter. So either or. That would be step 3 or 4. So step 3 is combining a long-acting beta-agonist with a low-dose inhaled corticosteroid, and then of course your rescue inhaler. Remember, all patients with asthma have that rescue inhaler. And then step 4 is the long-acting beta-agonist plus a medium-dose inhaled corticosteroid, and then their short-acting beta-agonist. Again, if you continue to use your inhaler more than 2 times a week, you have to keep moving up. So step 5 is a high-dose inhaled corticosteroid. If there's any indication that the asthma may be due to allergies, you can consider this drug called omalizumab, but I think this is relatively under the scope of USMLE. And then step 6 is to use an oral corticosteroid, and usually these are patients who are frequently showing up at the hospital. Another way you can visualize this is with this chart. So you want to look at it that way. Whatever diagram suits you better. Okay, so basically to make a complicated thing less complicated, some shorthand hints. As I mentioned, all asthma patients are going to get short-acting beta-agonists. They're all going to get their albuterol inhalers. They need that for their acute symptoms. If a patient's having symptoms more than twice a week, they're going to need some kind of an inhaled corticosteroid. If they continue to have symptoms more than twice a week, generally that means you're going to have to bump them up a level. If a patient is having symptoms every day, generally that means as far as the beta-agonists go, they're going to need a long-acting beta-agonist. And then this is just a generality, most patients who have asthma are usually in step 2. Most of them, though, are in step 3. So step 2 or 3. And some of them are in step 4 of treatment. So they're in this range here. Patients who have asthma that's got no triggers, as I mentioned, if it's exercise-induced, pentander-induced, usually they're in step 1 because they might go around their trigger and then they get their symptoms and they can get rid of it and get out of that situation. Okay, how about emergency management of an acute attack? So what are the emergency presenting symptoms of asthma? Well, of course, we have our classic dyspnea, shortness of breath, wheezing, and prolonged expiration. Generally, when people come into the hospital, it's because either 1, they don't have their inhaler, or 2, they're using their inhaler and it's not working. Either of those mean, though, you've got to treat this patient. So when you look at the patient, the first question you need to ask yourself is this truly emergent asthma, or is this just a mild asthmatic attack that we just with the nebulizer? If they're using their accessory muscles to breathe, so if they've got their head, their neck straight up, and you can see that they're using their sternocleidomastoid, if they've got intercostal retractions, if they're sweating, or if they have diminished breath sounds or fatigue, this is a medical emergency. So you have to differentiate this out from just your basic asthma symptoms. I mean, both are going to warrant treatment, but if you've got these alarm symptoms here, you're going to need to get at this immediately. You want to rule out foreign body, so when you're listening to the patient with your stethoscope, with asthma, you should hear wheezing throughout the lung field. With a foreign body, you would have unilateral wheezing. Stridor is not going to happen in asthma, but it does happen with a foreign body. And then mucus, either through the nose or through the mouth. You may see the foreign body. You may get a chest X-ray if the symptoms are not severe. So if they just got just a little bit of dyspnea, a little bit of shortness of breath, but they've got a good pulse ox, you can get a chest X-ray. But a lot of times you're going to know it's a foreign body based on your history. A lot of times it's going to be a 3-year-old, a 4-year-old, or younger. With anaphylaxis is another thing that can mimic asthma, but with anaphylaxis, it's usually going to come up on a history of bee sting, exposure to peanuts, exposure to something they're allergic to. But a lot of times you'll be able to tell physically because there's swelling or flushing of the face. The oral or pharyngeal mucosa may be red and inflamed. Rhinorrhea, stridor, or even hypertension may present anaphylaxis. Those aren't things that we see in asthma. So provided you've ruled out physical obstruction or anaphylactic reaction, the best initial step in the management of an acute asthmatic attack, or anything that resembles an acute asthmatic attack that's not foreign body or anaphylaxis, is going to be a short-acting beta-agonist. This is given either as an inhaler or in an nebulizer. I would give it as an inhaler if the patient is less severe as far as the symptoms, and they're an adult. With kids, it's generally just easier to give them the nebulizer. As you're monitoring them, their saturation should remain at 90% for
the hell you want, bitch?
Then we need to be doing something more. Of course, at the same time,
giving
supplemental oxygen, and that's why I prefer to use a nebulizer in most people, because you're giving that supplemental oxygen at the same time you're giving the albuterol. And remember, principally to all of this is that you're watching your ABCs. At the same time that you
Sorry.
should be getting labs.
Oh.
So you should also be getting arterial blood gases as soon as possible, and that's because we want to get a blood pH and a arterial oxygen. So in the early stages of an asthmatic attack, generally the patient
Good job. High five.
respiratory rate. However, without treatment, as the patient begins to tire, this will shift to respiratory acidosis. So what happens then is we kind of alluded to this earlier. If the patient is an emergent asthmatic attack, but they have heart disease or they've got congestive heart failure, and you really don't want to use a beta agonist.
What happened?
We're concerned about possibly setting them into an arrhythmia. And the answer to that is use your buddy. So if the patient's having more of a minor attack, and
Let's go.
So anticholinergics would be ipratropium or tiotropium. So they may prefer if it's just a mild attack, but the thing is that they take longer. So if you have more time to burn and the patient their saturation is 90%, even though they're having asthmatic symptoms, if you really don't want to use a beta agonist, you can use an anticholinergic. However, if it's a severe attack and you've got less than 90% saturation, you're going to want to go with a beta agonist because they're faster. Certainly remember that if you're not getting oxygenation, the heart is going to have to work harder. So that's not doing a heart patient any favor by not providing them the beta agonist if they really do need it. But it's going to be a clinical judgment issue. So if the patient continues to decline after the use of an inhaled or nebulized beta agonist, meaning if they continue to be below 90%, then you can use an IV beta agonist. Usually I think the number is something like after the inhaled or nebulized beta agonist, about 70% or more of patients come out of it. You can also, if that's not enough though, you can use an IV beta agonist, primarily terbutaline, or you can give them Heliox, which is a mixture of helium and oxygen, and that tends to penetrate into the lungs a little bit better. But there are limited cases in which endotracheal intubation is sometimes needed. Any patient with an asthmatic attack that's resistant to the beta agonist inhaler or nebulizer should be admitted to the hospital for at least 24 hours of observation. Our topic of discussion here is going to be pediatric asthma. Now, I talked about asthma in a previous section in the internal medicine lectures under pulmonology, and that information, while it focused on the treatment for adults, the pathophysiology and the pharmacology of the medications that we use, it's all the same for pediatrics. Asthma has a tendency to develop during childhood, so you really can't talk about asthma without considering it to also be really a pediatric disease too. We're going to focus here on the pediatric side of asthma, which the difference is going to be in how we go about managing it. There are some medications you can give to adults that you can't give to children. So I want to focus our attention on that. But if you watch the asthma lecture in the internal medicine section, you will see that it's very similar, and I do talk about some things I'm not going to go into here in a little bit greater detail. All right, so we're going to just brush over some of the basics, some of the pathophysiology and stuff, and then I'm going to focus more here on treatment in children. Alright, so here's our vignette of a 4-year-old boy presenting to the clinic with his mother complaining of persistent nighttime coughing over the past 10 days. There has been one episode of emesis, and his mom says that his temperature has been running around 99 to 100 degrees Fahrenheit during the past week. Mom denies knowing any sick contacts, but she is aware that, quote, the cold has been going around, unquote, at his preschool. There have been several episodes similar to this in the past, but this episode has been the worst. He was born via uncomplicated spontaneous vaginal delivery with an unremarkable neonatal course. He's fully immunized. His past medical history includes mild eczema since infancy, which has been successfully managed conservatively. He's tracking around the 45th percentile, both for height and weight. His vital signs show a temperature of 100.1 degrees Fahrenheit, heart rate 95, respiration 25, blood pressure 90/70, and he's satting at about 97% on room air, and he's in no apparent distress. On physical exam, you know mild erythema, edema of the lower eyelids, foggy nasal mucosa, and clear discharge. The remainder of the head, ears, nose, throat is unremarkable. Chest is hyperresonant to percussion, diffuse bronchi and wheezes are noted, no respiratory distress. Heart is regular rhythm and no murmurs, abdomen is soft, non-tender, non-distended, and he is grossly intact neurologically. Alright, so if you want to pause it here and take a closer look at this, feel free to do so. Alright, so this child, you can imagine, probably has asthma because that's what we're talking about here. However, there are some things that are going to point us towards asthma, in this case, and point us away towards other possible things that can give you a child with ongoing lung issues, put it that way. So the chief complaint here is persistent nighttime coughing. Coughing at night is not unusual. There's maybe a viral respiratory tract infection or allergies or something like that. It's not unusual to have nighttime coughing, but to have nighttime coughing every night over the last 10 days, that is unusual. That points to some kind of significant process going on. What else do we know? Well, we know the cold's been going around at his school, meaning that this may be infectious. But we also know that there have been several episodes similar to this in the past, and that points us away towards this being strictly infectious. Now, that being said, this can be both infectious and asthma, and oftentimes that happens where a child who has asthma develops an upper respiratory tract infection, like maybe bronchitis, viral bronchitis, and then goes on to have exacerbation of their asthma symptoms. So that may be what's behind this. We also know that he has had mild asthma since infancy, and that is part of our, or this may be part of our atopic march. Remember the atopic march? You start out with some kind of allergic issue during infancy, typically it's eczema, and then the child gets older and starts to develop allergic rhinoconjunctivitis, and then ultimately, as they get close to preschool age, kindergarten age, they start to develop asthma. That's the atopic march. Remember, all of those atopic disorders, they're highly associated with one another. So it's not uncommon, actually really is much more common, to see a child with one atopic disease also have another atopic disease, including asthma. His vital signs don't really give us much to work with here, other than his temperature is elevated. It's not past the fever threshold, which would be 100.4 degrees, but really, no child normally runs around 100 normally. So this is high end of normal, which may be significant. On physical exam, you note that there is signs of clear allergy here, but it may also be related to viral infection. So the erythema and edema of the lower eyelids can point to chronic allergy. The body nasal mucosa can point to that as well. Clear discharge, this can just be allergic rhinoconjunctivitis. But it's really hard to know just based on this alone. You look at the chest, listen to the chest, you know hyperresonance, that's classic with asthma. So with asthma, there's a tendency to be overinflated, hyperinflated, and that's going to cause hyperresonance to percussion. Diffuse bronchi and wheezes, that can be part of viral bronchitis, but it can also be part of asthma as well. So you can see the two of these kind of go together once in a while. Like I said, you can have asthma exacerbated by a viral infection. So what's our differential? Of course, asthma. Acute viral bronchitis. This can be acute viral bronchitis alone, can certainly manifest like this, or it could be asthma superimposed and acute viral bronchitis, or acute viral bronchitis superimposed and asthma, same thing. How do we know that, or how do we know that acute viral bronchitis is not at the top of our differential? It's less likely than asthma. Typically, children don't get repeated several episodes of acute viral bronchitis, maybe a few episodes throughout childhood, but this kid's 4 years old. He's had several episodes similar to this, with this persistent nighttime cough. So, just based on the fact that acute viral bronchitis does not happen that often, that points us more towards that this is an asthma going on. Also, the fact that he has eczema. Childhood eczema is an atopic disease, and that's going to point us more towards another atopic disease being behind this. Pneumonia, theoretically a possibility. Some things that point us away from pneumonia is the fact that his temperature is technically in the normal range, and he just doesn't appear that sick. Pneumonia, especially if it's bacterial pneumonia, they tend to run higher fevers, typically coughing stuff up. We don't know necessarily whether or not this is a productive cough, so it's hard to say. But this is probably not pneumonia. Reflux disease. So I brought this one up here because there's that episode of emesis. And reflux disease can cause, if there is just a little bit of aspiration, it can cause that wheezing and bronchial reactivity because of the chemical effects of the aspirant. However, this is probably not reflux disease. And the reason why, you can easily explain that emesis from the constant coughing. So any child who's coughing constantly, they are liable to throw up. And it doesn't have anything to do with any kind of stomach bug or reflux, it's just because of coughing. It just, that happens in children very frequently. As a matter of fact, even with bronchitis, emesis is a common manifestation because of coughing. Typically, when children present with GERD, there is let me go this way. The chief complaint is not coughing. The chief complaint is typically vomiting or emesis. And a lot of times that can be so bad to where the child is failing to thrive because they're throwing up so often. They'll also, in cases where the child's old enough to talk, they can relate to you some pain that's consistent with heartburn. So if we go about treating this as asthma and it doesn't get better, then reflux disease is a possibility. So how do we go about managing this patient? Well, we should get a chest x-ray just to rule out pneumonia for sure. Chest x-ray can also point us towards some signs consistent with asthma, although they're very non-specific, things like hyperinflation. Pulmonary function tests. This is kind of controversial. Pulmonary function tests are a best way to objectively diagnose asthma, but they're not necessary to do to make a clinical diagnosis. So you can diagnose somebody with asthma without ever doing pulmonary function tests. Personally, I think pulmonary function tests are something that is worth doing for anybody with asthma when you establish a diagnosis, just to get a baseline, because as we're going to talk about, patients who have asthma over a long period of time, if they have severe asthma, they can actually get worse as far as with chronic inflammation or the airway remodeling, and that can result in some non-reversible disease. So I think it's always good to get a baseline, but technically it's not required. If you do get pulmonary function tests, you're going to have a reduction in your FEV1, which is characteristic of an obstructive disease, which is going to reduce your FEV1 to FVC ratio. Asthma would be consistent with anything below 80%. And so in this trial, we see 0.7 or 70%, and that improves with the bronchodilator. So we're going to talk about epidemiology and pathogenesis just very briefly, because I talked about that in the other asthma section. We'll talk about the clinical manifestations and diagnosis, how we manage this, and we'll spend most of our time talking about that, and then the complications and prognosis. Asthma affects 5 to 10% of Americans overall, but children are going to be more likely to have asthma than adults. The way this usually works is that you develop asthma as a child, and as they get older, some of them, not all of them, but some of them will become asymptomatic as they get older and not require treatment. Now, that being said, you can develop asthma as an adult or as a teenager, and it tends to be females that develop it later on. Boys tend to develop it earlier on. Hispanics and black children are more often affected with asthma compared to white children. Why is that? Maybe genetics, but probably due to the fact that asthma is more likely to happen, it's more prevalent in urban areas. And we know that in the United States, Hispanics and blacks are more likely to live in urban areas, whereas white children are more likely to live in rural areas or in the suburbs. In more than half of children, asthma will develop prior to 5 years, and typically that will be in boys. So a boy is much more likely to develop it early on, compared to a girl who's more likely to develop it during adolescence. And so as we see, prior to puberty, boys outnumber girls 3 to 1, but during adolescence, the sex ratio equals out. So much more girls are being diagnosed later on during adolescence. As a matter of fact, women, adult women, are more likely to have bronchial hyperreactivity compared to adult men. So this becomes much more common in women or females as time goes on. Just the economic side of this, among children aged 5 to 17 years, asthma accounts for a loss of 10 million school days per year and costs caretakers almost $750 million due to work absences. So this is a significant public health issue. The pathogenesis behind asthma is just acute inflammation of the airways, which can be precipitated by a number of factors. Generally, it is idiopathic. However, we do know in some patients, especially if they have allergies, a lot of times they will have a known trigger. At least one of their main triggers is known. So for instance, they know that being around oak trees can trigger their asthma. But it may very well be that there are other things that trigger their asthma. So it's very rarely one single thing alone. But in some patients, you will have things that they do know triggers their asthma or makes them more likely to have an asthma attack. The direct cause, like I said, is idiopathic, but in many cases, certain triggers can be identified. And generally, those are going to be environmental allergens. Airflow obstruction results from bronchoconstriction. This is manifested typically as difficulty on exhalation and is associated with wheezing. So difficulty on inhalation, that's going to be more things like croup and more things that are higher up in the respiratory tract. With asthma, it's a little bit more lower down, closer to the bronchioles and the smaller respiratory tract. So that tends to be more associated with wheezing. Things like laryngomalacia, tracheomalacia, that can give you more things like stridor, which is on inhalation. Although really severe asthma can have biphasic wheezing. Unlike COPD, as you should know, the airflow obstruction from asthma is going to be at least partially reversible. The classic symptom of asthma is wheezing, but there are a lot of other things that asthma can cause. So as we saw in this patient, it can cause nighttime coughing, coughing any time of the day, but particularly at night, shortness of breath, chest tightness, and a past medical history of upper respiratory tract infections. That may present as well, like it did in this child. There are some variants of asthma that are good to be aware of. Patients with just regular old asthma can have these variants as well, but you can also have people who don't have just general asthma who may have, particularly this first one here, which is exercise-induced bronchospasm, or exercise-induced asthma, as it's commonly called. All this is it's asthmatic symptoms that come on with exercise. And there are some people that don't have asthma that do develop asthmatic symptoms with exercise. That's the only thing that triggers their asthmatic symptoms. Then there are people who do have asthma, just general asthma, but exercise is one of their triggers. So it can work kind of both ways. Exercise-induced asthma will come on with exercise, usually during exercise or maybe slightly after exercise. Really just depends on how long they're working out, but typically it takes about 10 or 15 minutes for it to come on. How this is often described is cough and chest tightness. The cough is really going to be what predominates. So they start exercising, they get about 10 minutes into the exercise, and they start to cough. They'll often describe their chest as tight. When they try to breathe in, take a nice deep breath in, they'll start to cough. That breathing in is going to cause coughing, and that has to do with the hyperreactivity. Symptoms will be proportional to the intensity of the exercise. Generally here we're not talking about things like weightlifting exercise, we're talking about aerobic exercise. And then another thing here with exercise-induced asthma is that it is usually worse in cold, dry air as opposed to warm, humid air. So if they're doing aerobic exercises like swimming, where they're more likely to be in a more humid environment, wetter environment, that's going to be less likely to trigger their asthma than if they were to run outside in the winter where it's 20 degrees Fahrenheit. That's going to be more likely to cause their asthma. Nocturnal asthma is where you get the stereotypical manifestations of asthma at night, and wheezing may or may not be present, but generally the way this manifests is that you have wheezing that comes on during sleep, but it's not present during the day. And then another thing that's important to ascertain is the allergen triggers. So anytime you make an initial diagnosis of asthma, even if they're not being referred over to an asthma specialist, which in some cases they will be referred to an asthma specialist, if they're not, then you should be the one to get a good allergy history, which includes information regarding whether or not they have this constant runny nose, or if you ever use things like children's Claritin to make some of these symptoms better, like watery eyes or runny nose, whether or not they've got eczema, things like that. We also want to know information regarding their home environment, pets, seasonal allergies, and so forth. So I talk much more about allergies in other sections. You can go back and look at that if you want. Okay. A physical examination is going to vary substantially, and the reason is because you may have a child with just mild symptoms of asthma, otherwise well controlled, or just very mild asthma. You can also have a child who is in status asthmaticus, in which case they can be they can have respiratory compromise, they may be unconscious. So it's going to vary. But for the most part, the common way for asthma to show up is wheezing, chest tightness, coughing. Well-managed asthma patients can manifest no symptoms, whereas some patients present PD, like I said, with respiratory arrest, problems like that. Remember, doing your physical exam, when we talked about this, keep an eye out for findings associated with chronic allergies, allergic shiners, dandelions, allergic crease, and so forth. So the manifestations by severity, you don't have to memorize this, but just kind of keep an eye on here how this sort of, you have these base symptoms and then they kind of get worse as the asthma is worse. So with mild episodes, kind of like what we saw in this child, you can have breathlessness after physical activity, but generally they're able to talk in sentences while lying down. Their respiratory rate might be a little bit increased. In this kid, we saw a respiratory rate of 25. That's very upper limit of normal for somebody his age. But generally, with mild episodes, the upper limit of normal, if not a little bit, just modestly increased. And you may note, you will note during mild episodes of asthma some expiratory wheezing consultation, but they will not be using their accessory muscles of respiration, and their saturation should be in the normal range, meaning over 25 or over 95 on Roumare. Moderately severe episodes, these have all the manifestations of the mild episode, like the wheezing and stuff, but in this case, there is use of the accessory muscles of respiration. I should say AMOR. I screwed this up here. Sorry. So accessory muscles of respiration. So if you note that accessory muscles of respiration are used, so you can see things like sternal retraction, scalene muscle contraction, things like that, then this instantly is a moderately severe episode at the very least. You may note that the wheezing is louder. These patients tend to prefer to sit upright, and they can develop pulsus paradoxus, which is an exaggerated drop in blood pressure on inspiration. The respirations and the heart rate will be increased. The saturation tends to be low, but not that low, 91 to 95, should still be in the 90s. They may be agitated. Severe episodes will have all of the manifestations of the moderately severe episodes, but the heart rate and respiratory rate are going to be higher, and then the saturation is going to be lower. So saturation will usually run in the upper 80s. And then these patients will often assume the tripod position, which is kind of where they're sitting down with their hands on the ground in front of them. And then there's imminent respiratory arrest. This is what they often describe as respiratory fatigue, where they no longer have the energy to continue breathing. And so at that point, they start to develop a respiratory acidosis, their saturation drops, and they can start to develop confusion, exhaustion. A lot of times, these patients will then lay down, they might fall asleep. And this is important to pick up on because there are signs of asthma that kind of go away when there's respiratory arrest. So if you're not breathing as much, you're not going to notice much wheezing. Your respiratory rate may drop. And so the respiratory rate, while it's very high in a severe episode, if they start to go into respiratory arrest, then the respiration rate is going to go back down. And that may, you should know if a child's in respiratory arrest just based on their saturation. That's kind of a giveaway. But their respiratory rate may drop and go back into the normal range. And you might think, well, they're not in asthma anymore, but really they are. They're just in respiratory distress. Diaphoresis can be present, the decreasing breath sounds. The pulsus paradoxus tends to get worse with the severe episode, but then it's better, I guess you could say better, with respiratory arrest. Okay, so this might help you a little bit more here, so you kind of graphically see how these symptoms get worse into the severe episodes, and with the imminent respiratory arrest, these symptoms kind of start to vanish. So you know that their appearance goes from normal to then where they prefer to be upright, but then with respiratory arrest, they may lay down. The respiratory rate and the heart rate, the respiratory rate will go up as it gets worse, and then when respiratory arrest, it'll start to drop. The heart rate, however, should climb. The saturation is going to be what really will help you with determining the severity, because it's really, and this is sort of the end result of whether or not you're getting enough oxygen, is your saturation level. Wheezing will get worse. The more severe it gets, of course, then becoming absent with respiratory arrest. The accessory use of respiratory muscles is going to be worse with severe episodes, but you're not going to note it as much with respiratory arrest because they become fatigued. Pulsus paradoxus just corresponds to the drop in blood pressure with inspiration. It's worse with severe episodes. Not quite as bad with moderately severe episodes. It should be absent with mild episodes. So with pulsus paradoxus, it's defined as being present anytime the drop is more than 10 millimeters of mercury. Okay. So for diagnosis, we already talked about this. You don't necessarily need to do pulmonary function tests, but I think it's a good idea just to get a baseline. So spirometry would be what you would do. You're going to be looking at the FEV1 and FVC numbers. The FEV1 should be decreased. The FVC is typically normal. However, if it's very severe asthma, it can be decreased as well. But what ultimately happens here is that your FEV1 to FVC ratio drops. All right, and then when you administer a bronchodilator like albuterol, the FEV1 should increase by at least 12%. That would be considered the reversible obstructive lung disease. Now, in cases where you suspect asthma but the spirometry is normal, you can administer a methacholine challenge. So there's some children whose asthma is so minor that they really don't have any whatsoever stigmata of obstructive disease. And so you go and do the test on them when they're otherwise not in an asthma episode, and they're totally normal on spirometry. What you can do is test to see how reactive their airways are by giving them methacholine. And what we would expect to see is that they have an increased sensitivity to it because they have asthma, and asthma is bronchial hyperreactivity, and that includes hyperreactivity to methacholine. That's really beyond the scope of the test as far as knowing how much methacholine they would need to be reactive to in order to diagnose them with asthma. But that's the way that we can diagnose them on spirometry in cases where the spirometry was normal otherwise. So here is our flow diagram. A would be considered normal. So here we see the peak flow generally is, when you're talking about a patient with mild asthma, is really not that different from the normal